Hello guys, welcome to the channel The Surgery Times. Follow us in Instagram, Telegram as well as YouTube. So today we will discuss about the management of renal stones. And here we will discuss mainly the surgical management because the medical management we will discuss with the etiology because after knowing the etiology of the stones, accordingly the medical management should be given. Hence, I will discuss here the medical management part, but you can easily correlate in our next session of etiopathogenesis of renal stones, that is urinary tract stones totally. We will discuss. This is basically urinary tract means starting from the renal means only kidney. Here we are discussing the urinary tract stones, that is renal, ureter as well as bladder. So coming to our discussion, urinary tract stones can be managed either by emergency or elective settings. So if emergency cases, the patient will complaining of pain and the pain is mainly referred pain. That is, the pain occurs in the lumbar area and it will refer towards the medial side of aspect of thigh or towards the back. This is the typical complaining of renal pain. Okay. So if you found out that it is less than 5 mm and if it is present in the distal ureter, so fast the it will pass spontaneously. Remember this one. But as the pain is there, in emergency cases, you should give NSAIDs, preferably diclofenac, and maintain the GFR. If after giving NSAIDs also, if the still pain sustains, then need urgent treatment of the pain. Whichever from these available in your setting, go for that. That is ESW, cystoscopy, ureteric stenting, or primary ureteroscopic stone retrieval, or laser trypsy. If the patient came with sepsis, then go for PCN under local anesthesia or cystoscopy and ureteric stenting as per availability. Now, in case of elective settings, there are many procedures are there. We will discuss one by one. ESWL, ureteroscopy, PCNL. These are mainly we will discuss. And next is open stone surgeries and medical treatment. This is what I was telling. Medical treatment you can correlate easily with the etiology. Okay. So why the stone occurs? Accordingly, the management is. So we will discuss one by one. First is elective setting. In case of elective setting, as per our discussion, first is ESW. So first is full form is extracorporeal shockwave lithotripsy. So lithotripsy is stone destruction. Shockwave, how? By shock, giving shockwave. How it is given? It can be given through USC and many procedures also there. So you have to generate one shock and it will given to the area pointed the stone and followed by destruction of the stone. Remember this. Next is this is non-invasive procedure. All these Q marks are important. Next is stones up to 1.5 centimeter. Many are in confusion. What is the stone size? Anything? And remember this is from the textbooks only, and you should remember this for MCQ examination. Stones up to 1.5 cm present in kidney, pelvis, or upper ureter. Ideally, ESWL. And here, more than one treatment session may be required because once the ESW is given, okay, it will destroy the stone, but the residual stone might be there, which can come to a down towards the ureter and aggregate over there also. So multiple sessions of may be required for removal of the stone. And another is cystine stones. These are relatively resistant. Hence, ESW is may not be effective in those cases. And for cystine stones, stovage stones, we should prefer PCNL. We will discuss in our next slide. So, what are the complication? Complication can be infection, hematuria, okay, parenchymal hemorrhage, and perirenal hematoma. Now, another word you should remember: stin stress. Okay, stin stress. Stin stress means I already discussed here. Whenever there is after ESWL, there is collection or aggregation of the stone fragments collecting in the distal ureter. Okay, this is called in the post ESWL. This process is the strain stress. This is a difficult word. Remember this, and it is otherwise called as street of stones. Now next is contraindication. In Smith urology, there are three contraindications given. One is obesity, pregnancy, oral anticoagulant. So how the oral anticoagulants are contraindicated? Why? Because it can come retroperitoneal hematoma. Okay. Also, already we discussed peritoneal hematoma can be occurred, parenchymal hemorrhage, and the patient is already taking oral anticoagulants. Hence, it is contraindicated. But nowadays, as there is availability of low risk, high risk anticoagulants, hence it can be given in practical purpose. But for MCQ purpose, always remember this is contraindicated in case of ESWL. It is given in the textbooks. Okay. Now, next is pregnancy and obesity. Obesity that is more than 300 lb. This one is important. Okay. Now next relative contraindications are distal obstruction, renal dysfunction, infection, and hematuria, as well as large aortic abdominal aneurysm and cardiac pacemakers. Now our next elective setting we can try for ureteroscopy. Ureteroscopy means this is the kidney, ureter, bladder. Okay, through the urethra we will go towards the ureter and take out the stone. It can be rigid, semi-rigid, flexible. Frequently used is semi-rigid, and this is less than 6 mm. Distal ureteric stones are preferably removed by wire removal baskets, Dormia basket, or lithotripsy. Out of this, lithotripsy most commonly used. Okay, it came in exam also once. Now, complication of ureteroscopy is it can injure the mucosa or wall of ureter, so that there is chances of perforation, extravasation, and ureteric stricture also can occur. From the diagram, you should remember this. Don't mug up all these things. Okay, but these are important in exam point of view. Now, ureteric stone, if it is less than 5 mm, pass spontaneously. If more than 5 mm, impacted calculi. The Dormia basket already we have discussed over here. Fine. Now, next is few points about bladder stones. I have written here. And open is cystolithotomy, not done nowadays. Open bladder surgery and taken out of the stone. But now what are using is mostly Holmium YAG laser as compared to ND YAG. This is ideal, important. But ND YAG laser is ideal in case of carcinoma bladder. This is a important question also. Remember this. Now next is TUCL, that is transurethral cystolithotripsy. Means transurethral, through the urethra, follow the line, through the urethra we will go transurethral cystolithotripsy. Through the ureter you can break the stone and take it out. Now next, third one is PCNL, percutaneous nephrolithotomy. Okay, here I am drawing the back of a patient. Okay, these are the kidney two side. So what we will do is, one, we are approaching through the back. Okay, through the skin, that is percutaneous. Okay, nephrolithotomy. One tube is inserted inside after taking out of the stone, and the nephrostomy tube, that is this tube, should be left in the kidney for 24 to 48 hours. Why? Because the residual stone may come out through this. Hence, you should keep it for 24 to 48 hours. Remember this. And indication is very, very important. And there are two sentences given in two books, that is more than 2.5 cm, okay, or more than 2 cm. So remember, more than 2 centimeter given in Campbell. Okay, don't confuse and don't go through the other books. Remember this one. This is from direct Campbell 11th edition, and more than 2 centimeter are indicated for PCNL. Now other cause indications are, first is obstruction, pelvic ureteric junction obstruction, calyceal diverticula ureteric obstruction after ESWL. So already we have seen after ESWL, okay, if the ureteric stricture is there, then we should go for PCNL. Next is obese. All the contraindications of ESW are indication for PCNL. Remember easily. And lower calyceal stone, important. And already we have discussed cystine stone, Struve stone, because these are hard stones. PCNL should be ideal. Now complication. Complication you can see as you are entering through the percutaneous level, it can puncture the perirenal organs like spleen, pleura, colon, and it can hemorrhage can occur. If hemorrhage occur after PCNL, then first management is embolization. If embolization is failed, then nephrectomy. This is important. Remember this much. And other complications like sepsis, extravasation, retained stone fragments, and also it is itself is a complication for open surgery. Okay, once you have done PCNL, if again the renal stone occurs, then you should go for open surgery, and it will be more difficult because after opening the body or cavity, there should be adhesion or fibrosis for the next surgery. Hence, it is after PCNL, it's more complicated for open surgery. Remember this one. And also important point is sandwich technique. Only remember this key for Staghorn stones, we should go for ESW followed by PCNL, because already we have discussed Staghorn stones are very hard and it may require multiple sessions. Hence, sandwich technique means first ESW, then followed by PCNL. As two processes are required for these two procedures, hence it is sandwich technique. Next is open stone surgery. Remember this much: pyelolithotomy, ureterolithotomy, nephrolithotomy. Not done nowadays, old procedures. Now, next important is nephrectomy, where the kidney is already removed, and subcapsular nephrectomy done in case of xanthogranulomatous pyelonephritis. Means kidney is here. Okay, this is the capsule, and the subcapsular nephrectomy should be done as surrounding the in the genthylomatous pyelonephritis there is fat standing and all are surrounding the kidney. Only kidney is removed, left behind the capsule. And nephrectomy is also done in case of recurrent pyelonephritis and recurrent renal abscess. Now the medical management, here we will discuss the management, and important is goal. What is the goal of medical management? Because people are asking if it is in the lower tract stones, then in medical management can be done and ideal. It is not like that. The medical management goal is to prevent further formation of new stones. Okay, no new stone formation and no further growth of existing stone. Okay, these 2 points you should remember. Okay, no new stone formation and no growth of existing stone. And the urine output in 24 hours should be maintained to 2.5 liter. This is the target. Okay, now next is just 1 minute. Urine output should be maintained 2.5 liter per 24 hour. And one by one, we will discuss about the cause of the stone and accordingly treatment. The mechanism we will discuss in our next session. First is idiopathic calcium lithiasis. Here, thiazide diuretics, orthophosphates, cellulose phosphates, and citrate mixtures are used. You can see thiazide and orthophosphates are most of the cases we are using, and because these are decreases helping in decreasing the urinary calcium excretion. Citrate mixtures increases the inhibitor activity of the urine, hence they are used. Next is hypercalcemic disorder. Already calcium is high, hence fluid intake should be more, along with orthophosphates, thiazide, and corticosteroids in case of sarcoidosis in order to decrease serum calcium. Renal tubular acidosis. Here we will don't remember this one. We will discuss in our next slide. So renal tubular acidosis, only citrate bicarbonate or sodium or potassium bicarbonate should be given. And cystinuria, I will discuss about the cause of cystine stones. Now remember the medication are D-penicillamine, 6-mercaptopropanyl glycine and captopril, as well as dietary methionine restriction. Okay, and the pH, urinary pH should be alkaline 7.5 to 7.8. Now uric acid stones which are arises from the hypoxanthine to xanthine in presence of xanthine oxidase. Okay, in presence of xanthine oxidase, hypoxanthine to xanthine, then uric acid is formed. But allopurinol what is done? Hypoxanthine oxidase inhibitor, hence it will not allow formation of uric acid stones. Next is primary hyperoxaluria. Oxalic acid, if increases, the inhibitors like pyridoxine should be given and orthophosphates. Enteric hyperoxaluria, first is fat restriction, oral calcium supplements, and cholestyramine should be given. So, if stones associated with infection, then antimicrobial antibiotics should be given for 3 to 12 months. Okay, remember this, important. Now next is dissolution of the stone can be done by polycythria, bicythria, hemiacridine or Subi G and M solution. So remember polycythria and bicythria. Polycythria is potassium and sodium citrate and citric acid, whereas bicythria, remember, only sodium citrate and citric acid. Now next is one procedure, remember, RIRS, retrograde intrarenal surgery. So here is the ureter. Here renal stones are removed via ureter. Okay, but not done usually, and this is mainly indicated in case of renal pelvis stone and mobile stones. You can try this one. So this much for the renal stone management. Important questions already marked as Q. Remember all these. And medical management already I have discussed, but it will better understandable when the etiopathogenesis will be discussed. Okay, so remember all these, and these are from reference of Campbell Urology 11th edition. Okay, Smith Urology and Bailey mainly. So thank you and subscribe our channel, The Surgery Times, in YouTube, Instagram and Telegram. In Telegram we are conducting daily quizzes also at 9:30 p.m. And so thank you all. We will discuss in our next session with a new topic. Till then, thank you. Goodbye.